So I have been allotted this topic, bone health in the elderly diabetics, preventing fractures and falls. Uh, as a part of introduction, bone formation and osteoblast function are impaired in persons with type 1 diabetes. BMD is increased, but bone quality is reduced in persons with type 2 diabetes. And hip fractures, the fractures which carry the highest morbidity and mortality, occur almost 2 to 3 times more often in those with type 2 diabetes than those without type 2 diabetes. And older adults, can this be? Yeah. Older adults with type 2 diabetes who sustain fractures are more likely to experience postoperative complications, longer hospitalization, greater healthcare costs, and loss of physical function and independence than individuals without type 2 diabetes who sustain similar fractures. So a quick look at the pathogenesis of diabetic bone disease. The deficiency of insulin and insulin-like growth factor 1 leads to decreased bone formation in more specifically in type 2 diabetes. Advanced glycation end products inhibit osteoblast differentiation and inflammatory agents like interleukin 6 and tumor necrosis factor alpha, they are pro-inflammatory. They can promote the proliferation and differentiation of osteoclast precursors cells into mature osteoclasts, and this will accelerate the bone resorption process. So it has been alluded to by Professor Punit sir, frailty and diabetes mellitus. They go in tandem as we encounter elderly diabetic persons. So what are the shared pathophysiological mechanisms between the two? Starting at the top, sarcopenic obesity, hormonal and metabolic changes, chronic inflammation, oxidative stress, and mitochondrial dysfunction. So once the elderly diabetes person, if he develops frailty, then he is very likely to encounter falls and fractures, and he's going to have a bad prognosis in the future. So we have to address both simultaneously. And 30% of people aged 65 years and above will fall at least once a year. And for those aged 80 and over, the percentage climbs up to 50. So our aim should be to prevent fractures in the elderly persons with diabetes. And this is an important snapshot of how we should be understanding the bone glucose interplay. It is from a 2024 publication. So I start at number one. We have to identify the persons with diabetes who are at enhanced risk for fracture. These are typically patients with duration of diabetes more than 5 years with evidence of micro and macrovascular complications, HbA1c persistently remaining above 8%, and if they have experienced hypoglycemia in the past, and if on board on board the treatment in form of treatment, if they are having insulin, TZDs and canagliflozin, they are more likely to sustain fractures. So what are the pathophysiological drivers? Hyperglycemia, advanced glycation end products, obesity, and insulin resistance are major drivers. And what can we expect uh, from the fracture outcome? So we have to be wary that these people are likely to get more infected and they carry more mortality. Hence, we should be looking at the box number 4, diabetes specific fracture risk assessment. We should be meticulously doing that and we need to consider treatment following any fragility fracture history. We have to screen the TL spine for evidence of vertebral fracture. And we must remember that while choosing anti-osteoporotic medicines, the BMD thresholds are lower for elderly persons with diabetes compared to non-diabetic persons. And we need to go to box number 5, optimize bone and diabetes treatment. So anti-osteoporotic treatment in general is considered safe for most of the elderly persons with diabetes, but we need to be choosy about the medicines that we use for addressing hyperglycemia. I think we can pick on some of the neutral or bone-friendly anti-hyperglycemics. So, bone treatment including bisphosphonates, denosumab, raloxifene, anabolic therapies, and other, they are all very safe for both persons with diabetes and those without. But in persons, especially elderly persons with diabetes, we may be required to give additional and supratherapeutic doses of vitamin D and calcium supplements, maybe for a prolonged period to ensure optimum bone health. And we may be required to advise them targeted physical therapy to reduce frailty and falls risk. And out of the armamentarium that we have at our disposal, neutral or positive effects are carried by metformin, DPP4 inhibitors, and GLP-1 receptor agonists. And GLP-1 receptor agonists, despite inducing weight loss, they have been proved to be bone friendly. They don't promote any bone matrix loss. And empagliflozin and dapagliflozin are two of the SGLT2 inhibitors who have been absolved of any crime of creating osteoporosis or increasing fractures. However, canagliflozin had that signal, and TZDs reduce bone formation. They are notorious. They reduce bone formation and reduce the bone mineral density and increase fracture risk. So they are best avoided in elderly population. Earlier we were thinking of avoiding them in postmenopausal females, but males are no exceptions. And in terms of sulfonylureas, which we still continue to use in a big manner, they are associated with risk of non-vertebral fractures. And in persons with type 2 diabetes on insulin therapy, what has been observed is increased incidence of distal skeletal side fractures. So we have to be moderate in our HbA1c targets, as Dr. Puneet sir already mentioned. We have to be offering more relaxed targets of time in range of fasting, PP, and HbA1c. So slips, trips, falls are no laughing matter. Exercise programs improve muscle strength, keep the joints, tendons, and ligaments flexible. And slow exercises like walking or climbing stairs up and down can also help reduce bone loss. However, the exercises for the diabetic seniors are captured here: flexibility exercise, balance exercise, strength training exercise, endurance exercise. These are the categories which are best offered to our elderly persons with diabetes. And sleeping adequately reduces dizziness and the chance of falling. Stand up slowly. That should be our advice to all our elderly diabetic patients, for to avoid instant drop of blood pressure, and this prevents one from feeling wobbly. And as clinicians, we should be measuring blood pressure in supine sitting and standing position to rule out postural hypotension. Good footwear like lace-up shoes with non-skid soles and low heels can increase the grip on slippery or smooth surfaces and support the feet enough to prevent falling. Make sure to walk slowly on wet or slippery surfaces. Bars and handrails are crucial for going up and downstairs, getting on and off the toilet without injuring oneself. And we need to ensure that there is adequate lighting throughout the house. So this is the second last slide, honorable chairpersons. These are all 6 golden tips to help prevent falls. The person with diabetes, elderly person with diabetes, should talk with his healthcare provider about medication side effects. He should be doing strength and balance exercises. He should be getting his vision and hearing checked regularly. Make his home safe by using night lights, installing grab bars in the bathroom, and securing carpets to the floor. Stand up slowly to avoid dizziness, and use a cane or a walker if needed for ensuring stability. So my final slide: in order to prevent fractures and falls in the elderly diabetics, we have to manage blood sugars meticulously, maintain good bone health through adequate calcium and vitamin D intake, regular weight-bearing exercises, and address potential complications like neuropathy with proper footwear, review medications that might cause dizziness, clear the clutter, implement home safety medications to reduce fall risks, and always we need to advise our patients to consult a SCP of their choice for a personalized guidance on fall prevention strategies. Thank you very much for your patient hearing.